Dr. Smith's talk was to follow mine, and we thought it'll be more fun if you get two for one. So we're going to both talk together because we've heard about MIGS, we've seen the various MIGS technologies, but let's put it into practice. Hear me? So if we got our slides coming here, yeah, I'm pretty loud also, as my wife says. So we wanted to sort of present a sort of a hypothetical. This is not a real patient, just so you know, but this is somewhat representative of the direction that glaucoma is going. Okay, we've had multiple conversations. There's one presentation. Well, they'll find it. So we had multiple conversations yesterday about, for example, SLT as an early and viable option. We had multiple conversations yesterday about the challenges of eye drop therapy. We're not rid of drops yet, but we recognize that there are challenges. And as we develop more and more procedures and techniques to control the pressure for the patient, as opposed to the patient having to control the pressure for themselves, we can imagine a very different landscape. Over the last 20, 30, 40 years, the stepwise approach to glaucoma has been one medicine, another medicine, another medicine, another medicine, somewhere in there, trabeculectomy or GDD, right? And so that makes sense in an era in which pharmacology was where innovation was happening. But now we have a new way to approach things, and that's with this concept of interventional glaucoma. So our disclosures here for Dr. Smith and myself, which are relevant, we will be discussing various technologies. The slides are advancing on their own, so I can control it. Yep. Okay. All right. So here's our, hopefully I can do it. All right. Here's our patient, our totally real patient. Okay. So patient's pressures are 24 and 25. They have a large cup to disc ratio, open angles, and otherwise a normal exam. I'll direct you to the OCT. The teaching point here with the OCT is if you just look at the RNFL, you might say, oh, they're totally fine. But if you look at the ganglion cell analysis, which is really, yeah, there we go. Here we go. So if we look at just the OCT of the RNFL, we see basically a lot of green, normal, great. Everything's fine. You just have ocular hypertension. Come back in a year. But if we look at the ganglion cell analysis, we actually see glaucomatous loss, respecting the horizontal raphe in both sides. So we see that sort of wedge. So this is pre-parametric glaucoma, but this is real glaucoma, and that pressure of 24 needs to be treated. Now, you all know what we're going to do first, right? Shout it out. What's everyone going to do? SLT, awesome. Excellent. Awesome. We're not going to put them on drops. No, we're not. We're going to do SLT. And in case you weren't aware, his fields are full. So this is someone, we're not going to sit on our hands and wait for their field to develop a problem, because that's irreversible. We already see that there's a problem. And the hope is one day we'll even catch things before the damage that's already occurred, right? So we still have work to do. So, okay, he gets SLT. This is 2019. Pressure came down to 18. Great. And then a little thing happens in 2019. I don't know if anyone remembers that. Yeah. Yeah, 20. Yeah, you know, started in 19. Some people got a cold, So, obviously we know that we lost patients to follow up during that period. So our patient comes back. Fortunately, it's so fortunate that he had SLT, because if he was dependent on medications and didn't have access to his pharmacy, he might have gotten worse, right? But SLT has protected. Yep.
We're on a drop, and the problems of medication refills for our patients at that time was a problem. We changed my outlook on eye drop. My patients now get 90-day supply. You get a 90-day supply prescription, and with refills on it, so that we don't end up with that situation like we did in COVID.
Right. So we, as we think about glaucoma therapy, I like to think about sustainability of therapy, right? So cost is a factor, access is a factor, comfort is a factor, visual consequence is a factor, and certainly effectiveness and disease kind of course is a factor. All right, so he comes back, his pressure has climbed up to 22, his OCT is still stable because most of this time he's been well controlled. So we have a number of options, right? We can repeat the SLT. That's totally an option. We could start drops, but we don't want to do that. And so for this gentleman, we elected to do a Durista. So that's an intracameral sustained drug delivery of bimatoprost. Let's see, maybe, can you try to play that animation on the bottom there? So it's about 1 millimeter in size. It's delivered through a 28 gauge needle. Okay. And this elutes bimatoprost for about 3 to 4 months, but we're seeing efficacy going on 6 months to 1 year in some studies of continued IOP reduction. So when we are able to do intracameral drug delivery, we're seeing a different kinetic profile and efficacy profile than we see with topical therapy, and a lot of hypotheses as to why. Okay, so we skipped that. All right, so we did the Durista, it worked for a year, and then his pressure started to come up. Now his cataracts are starting to get a little bothersome. And so we do cataract surgery with a hydrus. And here we can see the hydrus stent going in the angle, sort of. Apologize for it being a little bleached out there. So the hydrus is, as Dr. Herndon talked to us about, is an 8 millimeter long Schlemm's canal scaffolding stent. It covers about 25% of the angle and provides trabecular bypass. So it opens the canal and bypasses trabecular meshwork. And we'll play it once more. So here's an endoscopic view of the stent, kind of bridging 3 clock hours of the canal. You can actually see blood in the canal because it's stenting everything open. There's a reduced resistance to outflow there. So cataract surgery and hydrus, we've seen data that suggests that it works, and sure did. His pressure came down to 15. There we go. One more. All right, there we go. And Dr. Herndon spoke about this, that combining cataract surgery with microstenting reduces the likelihood of, we think it may reduce the likelihood of needing secondary glaucoma surgery. We also see in a post hoc analysis of the Horizon study, which evaluated this hydrus stent, that there's a reduction in visual field progression. It's almost a 50% reduction. These patients, these are mild to moderate patients at the start of the study. And remember, about 5–6% of these mild patients go on to need trabs or tubes in 5 years. So just because the patient is mild, when you're seeing them, doesn't mean they won't need something big in just a few years. And we see there are some people who do indeed progress quickly, and we can really have a marked reduction in the likelihood of field progression by making that interventional choice up front.
As we talk about that is the fact that, we've been doing MIGS for 10, 12, almost 15 years now. But we're starting to have data that actually shows us the long-term benefit of the surgeries that we're doing. And I think for me, that is a transition from actually doing a procedure to understanding the benefits, the true long-term benefits of doing this.
Right. We're starting to see sort of a disease modification, right? We're changing the trajectory of disease by our early interventions. And it's a different disease. Glaucoma becomes very different. I would argue easier to manage. Okay. So a couple years go by, he was doing great with this cataract and hydrus, but as glaucoma always fights back. Remember that. Don't ever let your guard down. So his pressure is back up to 22, and we don't like that. We've seen that OCT finding, which fortunately remains stable. So we put him on a drop. Sure, why not? Let's try it. And this is a patient, again, who's been controlled without drops successfully. And guess what he finds now? He doesn't like the drop. It works from a pressure standpoint, but it doesn't work from a sustainability standpoint. If you're unhappy with your vision, if you're unhappy with how your eye feels, are you going to take the medicine? Who's going to do that? For a disease that they don't feel, they don't see, they have no symptoms of, the only symptoms they're experiencing is the treatment. that's not a treatment worth taking, right? In a rational mind, right? So he's very eager to get off drops. And so after he talks to Dr. Smith at length, he elects to proceed with the AlloFlow procedure. So AlloFlow, Dr. Herndon alluded to it, is one of our newer suprachoroidal or superciliary outflow procedures, which shunts fluid into the superciliary space. So you can see here on the image, this is a scleral allograft, is in essence, that is placed within a cyclodialysis cleft. So a cleft is created gonioscopically and then expanded with some viscoelastic, and then a specialized piece of scleral patch is inserted into it to essentially maintain the patency of that cleft. And the early results are quite favorable. As you can imagine, cyclodialysis clefts are really good at lowering the pressure. So they do work. There is a lot of work yet to be done in understanding the space and how the wounds heal, etc. But in this patient, unfortunately, we tried something. The nice thing is it remains a safe procedure that doesn't take options off the table, which is very critical. So while it worked initially, he came back up and he was restarted on drops, which we knew he didn't like, just to control him until the next thing. All right, so now it's 2025 and we have all the greatest technology available to us. His OCT is still stable. He's going on 6 years of real glaucoma, basically with very little time on medication and a stable field and a stable OCT. So we are winning, but we recognize that we still have work to do. So we have a lot of options. We remain having a lot of options. We could still do SLT. We could go in and do a goniotomy. In my mind, and a lot of ours, when people have failed a modality, we generally don't go and repeat it unless there's a clear reason. Oh, it's because the stent was misplaced. Okay, they didn't really fail the modality. Let's try it again. But if we did it right, we accessed the right space and they still were unsuccessfully treated, repeating may not be as viable. So this is a patient who had all of his physiologic outflow pathways optimized surgically, and he's recalcitrant to that. So this is where, in my practice, we transition to non-physiologic outflow. And blebs are not physiologic. Let's remember that. That's why they fail, right? Because it's a hole in the body, and the body wants to seal holes. But we have a minimally invasive way to perform bleb surgery, as we saw earlier, with the Zen is what we have in the US, and hopefully you guys will have PreserFlow before we do, and then we'll come and steal it from you. So here is the Zen procedure. Go next slide, please. There it is. All right, so microinvasive bleb surgery, or MIGS, utilizes what we know about fluid dynamics to restrict outflow and reduce the likelihood of hypotony. That's our biggest dreaded complication of bleb surgery. And so you can play that video. So this is you've seen the Zen before, you've seen videos, and hopefully we'll do some today. This is a microfistula that's 6 millimeters in length and 45 microns in diameter that's placed through a 27 gauge needle. This can be done, as Dr. Herndon showed, via an ad externo approach, opening conjunctiva going from the outside in. The way it was initially described, and my preferred technique, is to go ab interno, whereby we do not need to do any conjunctival paridomy or dissection at all, which is, kind of nice. And so we can go to the next slide here. And so this remains a tissue sparing technique, which allows us to still perform additional subconjunctival or transscleral surgery. We can still do trabeculectomies. We can still do tube shunts afterwards.
Next slide.
So, great, you already have it. Okay, so here we go.
So our conversation, in summary, is to actually talk about, we've talked through a patient over the last 6 years of their glaucoma, in which case we haven't done a trabeculectomy or a tube shunt, and we haven't dosed or doused their conjunctiva with medicines the entire period of time. I think it's time to sort of change our mindset. IG is that attitude that is proactive. It's not reactive. It's one that causes an active monitoring of patients. It helps us to think about the options that we currently have available to us and causes us to look at our patients differently because of that. The goal of our intervention is what we come to work to do every day, whether it's improving quality of life, preventing blindness, being more cost effective, helping our patients to be compliant with medications that they get put on or the therapy that they get put on. If we think about how we've managed glaucoma over the years, it looks something like this. From one drop to the next, and possibly considering an SLT somewhere, filtering surgery, an aqueous shunt. And at that point in time, or rather at one point in time, that was the best that we had to offer. However, when we look about establishing what a new paradigm of treatment should look like, we had a patient who sort of transitioned over 6 years, but there are patients who that exact scenario that we just talked about will carry them through a period of 10 years. That saved our lifetime. You know, you went through, depending on how you cut their glaucoma. We're finding out that some of the things that we do now help us push some of these things further down the road. So a new standard for the future should look something like what's on the bottom of that page. And so what we bring to you and what we hope to help you achieve, at least in what you can economically find in the region, is something that looks like the light blue schedule of or paradigm in treating patients who have glaucoma. The thing about this is Dr. Henry sort of showed this slide, and I like this slide. It says, choose your own adventure. There's a time when we really didn't have an adventure. It was set in stone. You went from one thing to the other, and then it was 3. Somebody asked me yesterday, how many tubes can you have in the eye? You can have 3. And then it's CPC galore until hopefully that eye, the patient dies, or maybe the eye goes bicycle, or maybe not. But you do have an adventure now, and everybody can pick whatever their own adventure is based off of the options that we currently have available to us. Customize that treatment algorithm, however you choose it. There are publications that are coming out now that are helping people come up with their own interventional glaucoma algorithm of sorts. It may be different for each doctor because there's so many procedures within each procedure category. In summary, I would just say interventional glaucoma is a mindset. It is here to stay. It's important that all of us sort of get on the bandwagon, figure out the things that we can learn how to do. If you said 15 years ago, we would have an adventure that looked like that, there would have been many naysayers in the room, but we are where we are now, and we're moving forward with the mandate, so to speak, and making sure we continue to provide the best options for our patient. Having said that, I hope this has been informative. Dr. Shah and I thank you very much. We hope to see you all in the wet lab where every single device in that adventure sits on a table. Thank you very much.
Thank you very much. Dr. Shah, you can as well take the questions and answers. Yes, question, yes.